Let me introduce, bring up our experienced panelist. We have Dr. Miklos Sojka, who's the former Minister of State for Health Systems at the Ministry of Human Resources in Hungary. Sir, please come on up. We also have Mr. Varun Sood, who is the CIO and Head of Strategic Initiatives at Fortis Healthcare. Professor Angela Brandt is a full professor and founding director of the Institute for Public Health Genomics at Maastricht University in the Netherlands. Also, the Dr. T.M. Pai, Endowed Chair for Public Health Genomics at Manipal University in India. Please take a seat. And Director of the European Centre for Public Health Genomics. And we have Mr. Nathan Sigworth, who's the co-founder and director of PharmaSecure. Thank you very much. Please give him a warm welcome. A lot to add today. Thank you. So we've got a couple of short presentations for you here just to kick things off. And as before, I will ask a couple of questions. But again, your involvement, your questions and comments are always much appreciated and useful for this debate. But let me start, perhaps, if I could start with Dr. Sojka. I know you want to present some interesting data for us to consider. I know it's quite well, it's intriguing. I won't say any more. I'll leave you to explain it and come on up. Stay out of the way. I'll come in your seat just for a minute.
Thank you very much, and thank you very much for the invitation. And it's a real honor to be invited for this conference. And please don't misunderstand. Whenever I say something very easy about big data and things like that, I know it's a lot of hard work behind it. And I also do not want to say that we are more clever than anybody. It is just the Hungarian example, and that is what I would like to present to you. You know, it is. I'm coming from a country where the universal coverage is there. We spend about 4.5% of our GDP as a public expenditure on health, 7.7 total. So there's a very high percentage of private expenditure on health, concerning the money we spend on health, our health services perform well. There is a well-structured health service. A lot of heavy issues with equity, waiting list, accessibility of care, gratitude payment, informal payment to doctors. So we have a lot of issues. We are very good at immunizations and communicable diseases. We are losing out on non-communicable diseases. We are leading some charts on tumor mortality or cardiac mortality. So it's a well-developed single-payer compulsory health insurance system with state property and majority state property and care provision system. And you know, my job was manage 3+1 crisis when I get into office in 2010, and I served a full term. And that was public health crisis. So I had to make the Hungarians more healthy. And there was a sustainability crisis of the health services, so I had to make it sustainable, efficient, and good quality for everybody who gets sick. And then I had to manage a human resources crisis because due to the low salaries of the labor force, there's a very high medical migration in Hungary. And the +1 crisis was the world economic crisis. And the +1 mission for me is that I had to manage all this stuff in a way that the government does not lose the elections, but they win the elections. So that's for the preparations. And you know, these things were known by my predecessors. And you know, there was this perverted policy cycle. So the new guy came in. He had an idea. He or she had an idea. They intervened into the system, and they had to do it fast because the previous one didn't have too much time to do it. And then, for a certain reason, they had to leave. And there was a vacuum and disturbance left behind. What would be the prevailing idea? And most of the time, these policy and regulatory cycles went on and on and on. There came the new guy who took office, and in 20 years we had 12 ministers, which is an average life expectancy of 20 months. And under those circumstances did I take office. And you know, we did really a lot of stuff. a broad range public health regulatory stuff. We made Hungary smoke-free. We introduced a public health product tax, so the consumption of salt and sugar is dropping, and we generated money for salary raise. So there is an earmarked public health product tax, and the tax coming in goes into the salary raise of doctors. So the migration rate dropped pre-crisis level. So in 2014, the migration rate was lower than 2009. We also took over the ownership of hospitals and created a national health service. We redesigned the patient pathways, and we did many other things. It was just to give you an impression that there was a huge reform portfolio. And all this happened peacefully. I managed to survive for 4 years because this was consultation, and this was an on-purpose change management stuff, consultation with the people, preventing the natural resistance, only start regulations after we agreed, and I toured the country 3 times before I closed up the acute hospital care in 14 hospitals. So it can be done if you understand the underlying processes. And now, this is just the introduction. Now you should see how did we use the data? Because we started to use big data and network analysis on a systemic level. So number one, when we redesigned the patient pathways, you see these are the counties in Budapest, the counties in Hungary, and the migration of patients to other counties. You see that in the dark red county, only 68% of patients stay, and many of them go to the neighboring county. 11% goes to this red county because there's a university hospital there. So the highest level tertiary care is only accessible in the next county. This is the same issue with Baranya County. 25% of the patients go to another country with a university hospital. And from that county, almost nobody leaves, only 5% goes to other places. So we drew up care regions. But these care regions were not the same with the administrative regions. In a federal state, this would be impossible or almost impossible. But we could redesign the care map according to natural patient pathways. But we did not stop there. We also looked at the patient flows. This is a chart of the patient flows of Hungarian cancer patients. The dots are hospitals, the blue lines are patient movements of at least 10 patients. So we understood where do people go if they are not treated, or where do people referred further. This is the same network to the capital, to Budapest. And there you see intensive dark blue lines between 2 or 3 hospitals. Those are the focal points of cancer care. And you can ask questions. Why did that many patients traffic between the 2 places? Is it a lack of therapeutical capacity? Is it a lack of diagnostics capacity, resources? What is the problem? And for example, in one case, it was the lack of radiotherapy. But you do not want to invest in 2 radiotherapy centers in the same city, 1 kilometer from each other, but you want to organize the 2 dots closer. So you institutionalize that relationship, and you build on it, and you empower it. So these were the logical steps in the patient pathway reorganization. We also used network analysis for management control. What you see here is the analysis of hospital indebtedness. And on this chart, I saved 12.5 billion forints. $1 is 300 forints. So you have to divide that 12.5 billion forints by 300, and then you get it in dollars. But this was the analysis that we took when it took over the 100 hospitals from the municipalities. We took it over to state hands. And the blue are the hospitals, and the yellow are the various procurers of goods and services. And what you see here is not just a data and a graph, but what you see here is a market structure. What you see that there are 14 yellow dots that sort of monopolize the procurement for hospitals, while the hospitals were in the hands of different municipalities. So this was the chart that was shown in a Hungarian government meeting, and that's when I got authorization to introduce national level joint procurement. On energy we saved, on gas we saved 20%, on electricity we saved 15%. On pharmaceuticals, on the first 86 expensive and frequently used molecules, we saved 36%, just on the first procurement circle. And you see three big yellow dots at around 5 to 6 o'clock on the chart. And when we looked on the magnitude of those dots, then we recognized that there must be some banking operation behind that. So those unpaid invoices must have been financed by banks. So that's an illegal banking operation in the Hungarian public sector administration. So we turned to the companies and said, fine, we pay only 50% of the invoices, and then we do not ask questions. Are you okay with it? And they said yes. So on the size of those three dots, we saved 2.5 billion forints, and divide it by 300, and then you will get the amount in dollars. And we looked on those hospitals who owed more money to fewer companies, and that's a closed monopoly market pattern. If you look on those who owed smaller amounts to more companies, this is an open market, more competitive market. So when you look on big data and when you introduce network analysis, this is more than just data visualization. For those of you who understand your sectors, it will immediately reveal deeper unseen structures. So this is sort of uncovers the invisible. And we are just on system and management control level. And I tend to refer on it as science fiction, but I think this is already science non-fiction. And the reason I say this is that the software developers in Hungary already working on a mobile application, so this is a national agency, this is a national property stuff, and it will be operational in August. I have the trial version on my phone. This software will access all your health data, wherever it is in a clinical database in a hospital or in the health insurance database. We have a unique personal ID, so we are lucky in that sense. This administrative development was very lucky. So you can, so partly you can log in, partly you can search for various providers, but it does not stop there. If you have a Bluetooth capable blood pressure meter, then it will load it up to your phone, and the phone will load it up to a national cloud. So you can trace your lifestyle data, your health data. Of course, there's a therapy warning. So there's a new generation of compliance gamification. So we will give a tool in the hand of the citizen, and the data that will be accumulated is just unimaginable. Imagine all the Hungarian ambulance cars are equipped with transtelephonic electrocardiogram machines, and that will be collected in a national cloud. Imagine about the predictive capability, imagine about the automated diagnostics capability that the researchers might uncover. And this is just the blood pressure screenshots, and there will be blood sugar screenshots. And you have to know that in Hungary there's an incentive to keep your blood sugar levels right, because you can only receive 100% subsidy for analogous insulin if you have your lab levels right. This was one experimental outcome financing, and it works well. And it was only 20% of the treated people who fall out from that financing scheme, and a lot of them climb back already. So completely new payment systems, incentive systems can be introduced. And this is science fiction, but this is not so science fiction. This is all the diseases reported to the Health Insurance Fund. Which disease occurs with which disease? The large dot in the middle is cardiovascular. either the cause or the consequence of some other disease. So there is, in IMI2 documents, there is the need for, there is stated the reclassification of diseases, not from symptoms, but from genetic or whatever interconnectedness. Imagine that you put a genetic map behind this data set. Well, this is the treatment networks. You see concentrations of treatments that are followed by most of the treatments. How do you design patient pathways? How do you design a hospital? So this is just the first data analysis. We did not go deeper to it, but already the first look at the data showed us very interesting stuff. And this would be the last slide. And sorry if I took a little longer. This is a publication network. Those are Hungarian names, and those are and the question was who publishes with whom in the field of gastroenterology. And you see a blue diamond around 7 o'clock or 8:30 on the chart, Tulassai Zsolt. He's an old professor at the Semmelweis University, and everybody in his department has to put his name as a co-author on whatever article comes out. And you see a pyramid-style structure. This is publication data, and you see the organizational culture and the real organizational structure. Look at the guy around 12:30, Veres Gábor. He's a young gastroenterologist working with pediatric gastroenterology. He is linked to many other galaxies. He is if you lose one of the galaxies, he's still connected to 2 or 3 or 4 galaxies. So he is there. Completely different tactics, completely different position. And look at the guys around 3 o'clock or 3:30. There are 4 or 5 guys, Molnár Tamás being in the center, Farkas Claudia, a woman. So those guys work in a university in a countryside. You can take any one of them. The other 3 or 4 will still be very powerfully linked for everybody. So this is a teamwork. They help each other and they put together what they know. So when you look and imagine if you look on not only on publication data, but if you look on the data of the clinical centers, imagine what other patterns you can see in those charts. Anyway, I could continue for hours, but I think this was enough for now. Thank you very much for your attention.
Dr. Sośka, thank you very much. Fascinating, actually, how that data comes together. There's a very intriguing and intricate diagrams. Nathan Sigworth, I know you have something also to show us as we touch on this data question. So I'll leave you to, please, and then we can get some statements and get going with questions.
I want to hire your data scientists.
It's pretty intriguing maps, I know.
I won't tell them how much you pay.
Okay. So my name is Nathan Sigworth. I moved to India about 10 years ago to volunteer at a small hospital in rural Uttar Pradesh. And that began a journey that's lasted the last decade. In 2007, I started a company with my college roommate. We saw a lot of technologies being used to address counterfeit drugs, but very few of them actually making it to the emerging markets where counterfeiting was a big problem. And we focused on printing serial numbers on the drug packages themselves. Here's an example of those serial numbers. At the beginning, we thought that this would be a really interesting way to protect patients from counterfeit drugs. They could text this unique ID to a phone number, and we could verify that the drugs were authentic. What we discovered over the last 8 years since we did that is there's so much more than just protecting the distribution of medicines that comes from this data. And I'm just going to share with you quickly a little bit of that work. But before I do, around the time we started doing this and after, There's been a number of countries that have implemented regulations, including Turkey, India, China, Brazil, the US, the European Union, requiring serial numbers or barcodes on drugs. And so everything that we've done with this data at the company I started called PharmaSecure can be done on a lot of these drugs. And so I just want to give you a picture of the potential and where the industry may go in the next decade. So we began with allowing people to verify that drugs were authentic, either by typing in the code that's printed on the pack or by scanning the barcode with their cell phone. We got from that locations of suspected counterfeit drugs, as well as associating patients with the medicines that they take and the phone numbers and GPS coordinates. We've done this both with smartphones and with dumb phones. What we've begun to do in the last couple of years is follow up with those patients, with a sample of those patients, and ask patients of chronic therapies, when did you stop taking the treatment? We would call them at day 30, day 60, day 90, ask them, are you still taking this drug? Have you switched to a competing medicine? How much did you pay for this product? Who influenced your decision to switch to a different drug? And using these samples of patients, we began to understand some really interesting things. Here's some data from 10 tuberculosis medicines. Our company has printed serial numbers on about a third of all of the tuberculosis medicine strips in the country of India, with our partner pharmaceutical companies. These are 10 patients we called varying times after they registered that strip of medicine. We asked them, are you still taking it? Are you feeling better? This is just 10 patients. We can do this on millions of patients beginning today in India if we have the funding to put together the right incentives. I mean, the wealth of data that's sitting in the market today is phenomenal. Some work we've done recently has been moving from providing an incentive for people to register their medicines that gathers us data to providing reimbursement for that treatment. We've done on a small scale, if someone registers this tuberculosis medicine, we will reimburse them for the price of that tuberculosis medicine. As mobile payments comes into play, this system of using that serial number proof of purchase to provide payments and reimbursements to the patients can change the way that public health is delivered from a separate infrastructure to leveraging the private infrastructure and reimbursing patients for care. It can also change the way we price drugs. What if we could determine a patient's ability to pay, and at that moment, once they buy the medicine, they register that medicine based on certain factors, we're able to provide a mobile payment directly to that person based on that proof of purchase that reimburses them for a piece or all of their treatment. I like to think of it as financial aid for medicines. The power of this is really, really quite something. There's a number of companies. PharmaSecure isn't the only one working. There's a number of companies doing serialization. All the major pharmaceutical companies are printing barcodes and serial numbers on the drugs. The primary focus right now is regulatory compliance and anti-counterfeiting, and that's why these regulations have come into place. But there's a huge potential in this data that I think is just sitting there and waiting to be unlocked as soon as we can move to the next level. Thank you very much.
Nathan, thank you very much. Perhaps Professor Engelbrandt, I could ask you to give your comments to give us a perspective on how you see data, because I know you have a particular view on how data can be managed and what it can be used for. So please.
Yeah, first I would like to say thanks a lot. First, what I would like to say is when also listening to the previous speaker, it becomes very clear that also incremental benefit will be the driver of costs and the driver of sustainability of healthcare systems. So I think that really we need such disruptive approaches, and for me in the moment there are really two. And these are so disruptive in solutions, including also frugal innovations, reverse innovations. But one is the big data analytics, and the other are a form of trust where citizens belong to a trust, and these are health data cooperatives. And I think that would lead to maybe really a transformation of our health systems, and in the way to have on the one side health protection, and on the other hand complementary personal health and care. And these coming together, and then of course cross-cutting management and organizational structures. And but why are we there with big data? It came from the omics first, starting from other fields, of course, physics, etc., and chemistry, but in the medical field about the omics systems biology, the network analysis with Laszlo Barabashi from Hungary, and then also was understanding the microbiome, how the microbiome is interacting with brain functions, etc. And then all kinds of, looking at all kinds of data, so not only omics data, but social, environmental, because we are different because of the environment, not because of omics, but because of the environment, and that everybody interacts in a different way with so many factors of the environment, so all genomes are permanently changing day by day. That means that big data analytics by nature is structured data, but are also unstructured, semi-structured data. And that's the beauty, I think, that from the examples that we have no clue maybe how to interpret data, but from a bottom-up approach, collecting data can give us very different insights. And what would be incremental would be to continue in the way what we're doing now with data, so to have the population, subpopulation, smaller groups, so top down, and there we increase, I would say, systematic bias, how we look at things. Whether with a big data and bottom-up approach, it's different, and we would see correlations we didn't see before, and there are the examples of using Watson now for antimicrobial resistance, a huge problem worldwide. So to play around with the data and find solutions, that's one thing. And I think there are nice examples already very clear from the management and from the yes and no with planning of hospitals, of looking how to solve the problem of waiting lists. And now I come to the form how to implement it. And I think there came up the idea from Switzerland first, from Ernst Hafner, I have to say, the health data cooperatives. And cooperatives are not new in the healthcare system. We have them in Italy, in Japan, but not regarding health data. And that means that citizens create, own, and control their own data. They belong to a trust system. They all have one voice to decide what can we do when we earn money through that cooperative, when we share our data and provide them to different users. And the different users could be all kinds of stakeholders. So it could be industry in buying data from the citizens of the cooperative, or could be public health services, could be registries.
So just a clarification. So you have a group of people. It could be could it be a town? Could it be as big as a town or smaller? How, the cooperatives, how do they work with those?
It could be on a regional level, national level, global level. But the key is that people own and control the data. That's the one key point. The second is that they decide what to do with earnings of money when they share their data, and that's why, and Safen said, we are all billionaires somehow, because we all have a lot of data. And so that could be very interesting, that model for India as well, because the incentives, then it only works if if the incentives are not in terms of money, so that people do not get money in their hands, but decide, for example, for our community, we discussed it in the Udupi area, for example, in India, around Manipal. It could be to provide to people a health insurance, what we discussed
by
today.
selling the data, they get either a discount or get health insurance as a benefit.
Yes, a benefit, or it could be to decide we need a new hospital, or we know in Switzerland even they say, well, that citizen or patients doesn't have to pay for their imaging. All other data they get for free, but not, for example, imaging.
Actually, Nathan's, your system had that reward aspect, which really, yeah, so it makes people say it's worth giving the information. The only issue here is...
And the drugs are free, and you could also organize flipping trials, clinical trials, that the citizen create their own trials and control them. So it's and then also...
We're giving up our data, we may as well get something for it,
Yeah.
is I think the idea, right?
Yeah.
Exactly.
So this is an interesting idea, bottom-up ownership of data. People own their own data and can then use it in a commercial way, in effect.
In a commercial way, but not getting money in their hands.
Necessarily, yes, that's right. So some kind of return. Some kind
return
of
of
valuable return, in
yes,
this case, maybe
yes.
health insurance. The idea is that by pooling together, they create a larger pool of data, which gives it more validity, shows trends perhaps in a village or in an area as well, so they can do that. Are there any particular security issues or security concerns or risk to opening themselves up to excessive marketing or something? Is there any way to protect the individuals from
first thing I would say we have to be also very clear, or more clearer, more honest to people, to say we can never ever secure data. Yeah, or privacy. We can do our best, and also with quantum computing also. But for example, to put the own data in an own personal cloud would be a possibility, and then to connect. And also we have new instruments, for example, using the Apple Health Kit also to solve the interface problem. So I think we have technical solutions that's problem. And here the beauty of that model is because it's a balance of common good, public good model, and personal benefit. And because citizen ownership is really a shared right, a social right.
One thing at this stage, let me also get from you a sort of the best understanding you can give of what big data is, because I know when you talk about the big data, or people talk about big data, there's a lot of variation in what they understand it to be. Yes. So give your definition.
Yeah, it's much more than data linkage. Often people say now data linkage and open access, no, much more. It is really for the unknown purposes, unknown future purposes, unstructured data, and having no hypothesis at the beginning, and then to start. And so it goes much beyond just data linkage. And small and big data, in my understanding, doesn't make sense. It is a little bit misusing the concept in the moment to say, oh, we need only small data. And then the Europeans, the Science Europe now, they had a report on big data, and they said big data leading to big science. Yes, but I think big public health, these are the really drivers and challenges.
You've raised a lot of interesting points. I guess there's Nathan frothing at the mouth to add something here, so I'm going to get to him before Varun.
I guess I'm just curious, what's the difference between private ownership of data and sort of the common ownership of data that we just saw, in your data that's going to fix the whole system, and everyone will benefit from that, if only because their taxes will be lower because you've saved all that money. I mean, is that the same thing, or is that different?
The government would be stakeholder, and for example, also I think because you have the good governance. Here with you, when you had been in place as a minister, that was a real example of good governance, how to use it in the way. And although you did really very, not all people liked that. That's very clear, but it made a huge benefit. And I think to have a trust system where a neutral platform, where also, because even everybody has interests, but a trust system could lead to some more neutrality.
Let's do this. Let's carry on with this debate in a second. I also want to hear Varun on this, but but first let me get our former minister to answer this question of what's the I mean, the difference in ownership of data, because I know this is an important point. Thank you for your patience.
Sorry. So I think that's a huge issue, whether data is a public asset or a private asset. And of course, we all should own our own data, because that, whenever it is a genetic data, that's sort of part of our body. But when you look on Google or Facebook for a free large email account, you would be willing to share your health data that could be used for other purposes and for research purposes. They might take over big data research, and they have the aspiration to do so. And you know, it is, and this is a much more important issue than private insurance or public insurance. Whether the data could be a public asset is the number one issue in healthcare, and I'm very much for it. For example, if the EU data protection directive goes through, then the Swedes and the Scandinavians can throw out their public health registries because they could not ask the dead people to authorize the secondary utilization for their data. So there's a huge danger. And then who will be the winners? And you know, the scale independent networks has characteristics that those who have more will be given more. So Google and Facebook will be the winners of the European data protection regulation. So we have to put data protection issues to a completely different level. Snowden helped us to understand that. Sorry.
Well, I'm going to hold for a second now, so just so we can take a step back. So I want to get Varun Sood into this as well, and we'll get back to this debate because it's a very important one. If you could perhaps, so just give Varun the microphone. Varun, one of the key things is what we're talking about now is as a result of the way technology has changed. And it's a key factor. None of this could have been done prior to mobile phone technology, for example, or the internet and so on, and the kind of analytic data that allows us to collate and understand the information. So let me take a step back here and ask you how you think that technology can be leveraged. Technology can be leveraged to rethink healthcare systems.
That's a great question, and I must say, you know, very interesting debate. I was waiting to jump in at some point in time, but
Hold it close so we can hear you.
Yeah. So, you know, if you take a step back and let me start from an Indian context. So, what are the problems we face in healthcare? Well, the number of doctors, the quality of doctors, affordability, access, so on and so forth, and the list is long. But those factors are actually not just Indian, they're also universal in some contexts. So yes, you have a US which has a problem with cost of healthcare. It's 20% of GDP. A heart surgery in the US may be, you know, X dollars. We are 1/10 here, but that 1/10 in India is very expensive. You have a medical talent question of you know, quantity and quality at the same time, and those problems won't go away overnight. It's going to take 15 to 20 years before those problems start kind of going away. And like I said, these challenges will be universal no matter which country you go to, but they just vary in scale and size as you move across. So if we were to look at the traditional way that we've been approaching healthcare, I think that you know, we're not going to solve the problem in the next 20, 25 years for sure. So that's perspective one. So we have to think of new ways to you know, how would I say, keep people healthy. Why do we need to have people fall unwell, for that matter? I think the second perspective that I'll bring on the table is that, you know, if you were to look at it, we look at people as consumers of healthcare. So, you know, be it pharmaceutical or otherwise, you know, and we are looking at training doctors to do surgeries, etc., so on and so forth. But it's a very reactive measure. There is a lot of focus the world over on preventive medicine, on preventive healthcare, so on and so forth, which is going on. But it's actually it's not a consumer focus. It's still how, you know, if I was to use the word, a patient-centric wellness approach. It's not a consumer-centric wellness approach. So if we were to actually flip healthcare over and think of it to saying, look, let's not think of making people well, but can we actually think of people as consumers and say, why don't you stay healthy? And then how do we go about doing that? And, you know, at end of the day, it will boil down to a couple of key factors which come into play. And, you know, like when you said in your you know, when you introducing me here. So you've got, you know, technology 10 years ago was in a, you know, a place in point For example, even for PharmaSecure, I used to work in a pharmaceutical company. Counterfeiting was a big issue, but the technology at that point was cost prohibitive to kind of put into play. It wasn't evolved to a point in time where you could actually do newer and funkier things with it. Over the last 4 or 5 years, we've actually seen the cost of innovating, the cost of technology, the cost of the affordability of technology really crash and come down to pennies and dimes for that matter. That's really come down. Second, there has been an explosion in innovation on what you can do now on a person, instead of waiting for the person to come to you. It is possible in today's day and age now to actually continuously monitor what you do. So you take the fitness example. So you have the Jawbones and the Fitbits, so on and so forth that work. Fitness is usually, in my view, wrongly assumed by people to be an indicator of health. It's a very small component. Very fit people can also fall very unwell, for that matter. Yeah. But now we've got technology at play which can actually capture your BP, your blood glucose levels, your heart rate, your pulse, your temperature, so on, and multiple parameters. You can do an EEG or ECG on a phone cover now. Okay. You can check for arrhythmia of the heart by just putting the phone next to you and someone is doing something for you. So the tech has evolved, and it's at a very cost, it's not expensive. But what it leads to is a lot of data coming in. And if we can actually come up with ways to create services, be it public or private, one way or the other, which are not targeting unwell people, but which is actually targeting 90% of the people who are well, so that you don't kind of load up the healthcare system by the end of it. Why invest in solving a problem which will take 20, 25 years to solve, whereas we actually invest in solving a problem which would actually reduce the burden as you move forward. End of the day, it all boils down to big data, because you will get the data. So you had what does big data mean? So I'll give you a different perspective. We normally look at, when you talk big data, and I've gone to a lot of places in India and overseas where the conversation is on analytics. Okay. But analytics of what is the question, and like she was saying. So, just because I've got, your physical parameters for the last 30 days or, maybe 10 years, that's not big data by itself. When I can correlate it to environmental aspects, to water supply issues, to so on and so forth, is when, or unstructured data for that matter, or what are you doing on Facebook, what are you doing on LinkedIn and on Twitter, because that linkage is what actually is big data. You get it all together, and then when you analyze it and you come up with the networks, or you can do root cause analysis. So I'll give you a very interesting example. There was an outbreak in a certain country of infections, people coming up with a big gastro problem, and a lot of volume of people coming in. They tried what they could. They look at and there was no sense on where the people were coming in from. They couldn't identify the root cause. So they took the health data, then they looked at the neighborhood, and they couldn't find a reason. They looked at ethnicity, so on and so forth. Nothing came out. They just happened to link it up with the water supply system. And they basically found that there was this one main water supply pipe which was coming in, which was going through most of those neighborhoods because of which the problem was occurring. So the problem was not a healthcare problem. It was actually a water supply problem. Now, it wouldn't have been solvable. I mean, you would have never known the reason for the problem till the time someone in the water supply department somewhere would have kind of woken up and said, today let me test and see if my systems are fine, or my thing is running fine. So I'll leave it at that.
No, this is interesting, because actually this has put a new perspective on data. It's not just about the information you have, it's the range of information you have across a number of parameters and how they all interact. Professor Brand, you wanted to add something again?
Yeah, two things. Two things. The one is because I always struggle, how do we bring in together that, put it in relation, the big data to environment, but also to interpret on the personal level, really personal. And then I thought, okay, we have all, first we need from all individuals all kind of data, all, including environment, also pollution, etc. And then we will see that measuring the data, there will be ups and downs, like modulating factors, getting with ups and higher. And then on the individual level, suddenly there might be a peak. And that would mean, on the individual level still, it would mean, okay, now we have to look in depth more, so correlation versus causality, what is maybe behind it to investigate. When we would see that different individuals, that is this, and suddenly many individuals in a community, there would be a high risk then we would need, there is now something going on, a hazard, and then again to investigate, and then maybe we would have found, and we come back to old epidemiology, snow and the pump and water supply, what plays a role. That's the one thing. The other I wanted to mention, one example on the health data cooperatives, where there had been such a model in place, not in place, but almost implemented, and that is in Malta, one of the smaller member states in Europe, and they called it different, I think, My Health Data or so. And they wanted to implement it. And then we visited the ministry and recently, 6 weeks ago, and asked, why did it not work? What had been the barriers? Because now we are thinking of such a model. And they said, yes, the barriers had been the doctors and maybe the GPs, because it's very transparent and we have an out-of-pocket payment, and of course, so it was blocked by the general practitioners. And I think we have also to be aware of these models. Where are the real barriers?
Yeah, existing models can be in the way as well. Let me do one thing. Let me see if any hands go up. Anyone particularly interested in asking an aspect of what we've been talking so far? Please do put your hand up and we can come to you at any point. I want to bring Nathan back in here and ask, one of the things we discussed early on was medicines, the importance of medicines and pricing of medicines as well. And now I wonder how with the data you collect, it can actually have an impact on medicine pricing.
Sure. I think this brings up an interesting point that relates to this idea of data. It's not just the data; it's the incentives to use the data. I mean, I think what you guys have done has been really impressive in terms of you had the incentive to leverage that data, to look at how we can change things. Here in Malta was a case where there was the data possibilities, but there was no incentive, or there were perverse incentives keeping people from using it. And I think in the pharmaceutical industry, we see a huge potential when it comes to pricing as an incentive to leverage some of this data. 20 years ago, the pharmaceutical industry had this horrific trade-off between access to medicine and profit for shareholders. I've spoken with entrepreneurs of generic pharmaceutical companies who decided to break patents and increasing access. I've spoken with executives at Big Pharma who had the heartbreaking decision, do we provide access at a cheap price, or do we bring the best return to our shareholders? And there was no good option, for these folks. I think today we're in a totally different place. We have the data, we know where the patients are, we have the ability to do payments, and I think that if we can do differential pricing, if we can leverage the data we have in the market to do differential pricing, not just by national border, which is what we've traditionally done as an industry, which is somewhat arbitrary, but if we can move beyond to much more specific pricing, and this requires change in regulatory, it requires change in patient privacy, it requires change in an industry that's usually averse to change in their methods. It's the pharmaceutical industry, but I think the potential to eliminate that trade-off and those incentives between access and profit and align the interests of patients and pharma, big pharma and generics, I think the potential is fantastic. And a lot of this relates to being able to capture that data and use it.
And actually, I want to turn to Dr. Soschka again and ask about what you achieved in your country. And that is, you seem to have a target. In terms of getting that data together, you already had, it seemed, targets in terms of salt, sugar, smoking and so on. Was the end goal created first and then the data collected and used to vary the end result, or was it that you got the data and thought, well, wait a minute?
So it is, there were decisions that we took that we need that kind of data to solve a problem later. But in Hungary, DRGs were introduced back in '93. And I remember I was already in a sort of a shadow government position back in 2009. And there came some international colleagues and we had a discussion with a guy who was heading the heading the unit in the ministry that was collecting the data. And this British colleague of mine asked the guy a question, and who do you write reports to? And the guy asked back, what reports? So we knew that we wanted to use the data, and we knew that this is a gold mine. So we prepared for data mining, and the digital maps you have seen on the first charts, the engine that put together the DRG data and the patient flow data, that engine was developed before I got into government position, with the purpose that we should use that digital mapping for the redesign of the health services.
Varun Sood, the one thing we talked about also earlier is leapfrogging, this leapfrogging of technology. India's benefited in many ways with telecoms, for example. Does it have the same kind of advantage when it comes to the healthcare system using the development of technology to leapfrog, or do you feel there's too much legacy and baggage?
Most definitely. I think we have the opportunity to actually leapfrog. Like you said, telecommunication was a case in point. I think it's we have that opportunity more so because the traditional approach will not work. So we have to innovate and think differently. And the brilliant part about technology is it's geography agnostic. I mean, end of the day, if it works here, it can work anywhere, or vice versa for that matter. The challenge comes into regulations and so on. Just to comment on one of the previous things. So privacy or ownership of data. So so a lot of times, a lot of people put a lot of information out without any context of what's going to happen with it. Facebook is a case in point. You're saying stuff all the time, putting things out all the time. End of the day, if you are looking at leveraging and keeping yourself healthy, who owns the data, I think, is a moot question. It's a secondary question. It's not the primary question that comes into play. Yes, you can incentivize it, but you can also disincentivize it. And it can work both ways. There's a stick and a carrot approach that works. What has to be done, in my view, is a larger good. I mean, if it is being looked at to saying, if we are looking at keeping populations healthy, if you're looking at keeping people healthy or healthier for that matter, who owns the data, I think, becomes a question more from the context of, will I get a marketing call, instead of saying, will you be using it? So, but the one concern which would exist is if a country has all my data and a corporation was to get to know it, will maybe I be discriminated against hiring while I'm being hired at? If my health risk index is high, okay. If my health data is out there and someone who I'm trying to work with is getting access to it, as in I'm just taking an example, will that bias them or will that cause an issue? And those are, I think, those are key questions more than the monetization. It's more we humans normally work on a risk on a fear psychosis more than a positive. So it's the fears which stop us from doing things more than the benefits that kind of drive us out.
Ironically, a lot of people in the US won't get tests because they don't want to jeopardize their health coverage, because they don't want to be penalized. A lot of people won't, a lot of information won't give out. And then there's also the other factor that once we start to accumulate more data with advanced sciences such as, genomic mapping and so on, then it comes down to, do you choose a partner based on what their profile is and so on, and et cetera, et cetera. So it does get more complicated. Professor, you wanted to add something, and then Dr. Soshka, you did too.
Several aspects. One thing was because starting with the genomic mapping, that exactly would have behind that again the linear thinking and deterministic thinking of genomics, because it is a permanent interaction with environment, and most diseases will, and we saw it with cancer now, occur by chance. And we don't know why one single cell gets out of control and why the equilibrium is no longer there. And then with you mentioned the privacy issue, and I think putting it not to continue with always informed consent, privacy, but also having their flipping approaches, like, for example, the user accountability of data, and then also having things in place like really good contract management. We have these kind of tools, and I think, but this other is really the elephant.
Let me just check. By the way, do we have our ladies with the microphones? They seem to have disappeared, because I do want to get our microphones out. So I don't know if someone from our team could just get the microphones out to our. Well, it's taking it out to the maybe I don't want to risk feedback if I go out there with Andrew. Could you do that, please, kindly? Yeah, actually, there's a lady behind you who was first, and I was going to give it to her first, but that's very kind of you, sir. I just want to, while we pass it over, it's the lady in the orange shirt. Before you ask your question, let me get a little response, because both Dr. Soshka and Nathan have something to say.
So it is, now we know that data saves lives. Data saves public money. And this is, so we understand that. On the other hand, there are millions of people who are willing to share photographs on internet and Facebook. Who did they go bed with after a drunk night? Yeah. And you know, so that's an issue, and they can. That doesn't save lives, but imagine that you share your genetic data and then you carry a risk and you get not insured. So this is a very high risk stuff. And you know, on Facebook, and you are a product. And imagine when your genetic identity becomes a product. Yeah. So we have to raise this debate on a much higher level, because in data there is our public money, in data there is our life, and there is the new therapies and more efficient, more targeted therapies. So we have to be very cautious with it. As a politician, if I go back to my old role, I could defend it in Hungary, and Finns go to the sauna naked because they do not have that protective, inclusive feelings. But this is culture. Some other countries would never do that, or would execute somebody for doing that. So we are different culturally. But now these social network sites, these are global. So there will be a global genetic identity trade.
And so a global culture, maybe a global culture to go with it too.
Yeah. So we have to prepare. We have to prepare for that. We have to start to talk openly about it.
Okay, Nathan.
So I just want to say quickly, I think we often put privacy as the paramount. At least healthcare in the United States, we often think of privacy as so important. But I think the reason we want privacy of our medical data is because of very clear economic incentives. Right. We don't want to lose our insurance. Yep. We don't want to lose our job. Those are two things that can be solved, I think, through other ways. I think we've seen healthcare changes in the US that makes insurance easier to get if you have a pre-existing condition. I think we can also see other changes in the culture and in the, in society that can address those issues, such that maybe the incentive, maybe it's not data privacy that's our biggest problem, maybe it's the incentives of what happens when that data gets out. And I think, data being aggregated, it's just inevitable. It's a matter of time. And I think if we can find ways to creatively and ethically and with whatever safeguards we can put in place, use that data, I think that's the only way forward, honestly.
Thank you for your patience.
My question is to Varun. So pardon my limited knowledge on big data, but whatever I understand is that the concept of big data, the entire application of what we have been discussing, holds good for the urban India. However, when we talk about the rural India, where a major chunk of the population resides and majority of health challenges lie, do you see any scope for taking this technology to the rural pockets? Or do we have a starting point, and do we see a potential for this technology there?
Who is it to, the question?
Varun.
Oh, sorry.
So I'll answer your question in two parts. I think, so big data is only going to work when you have data. So you've got to have the data first. So, a lot of the population, so even within urban India, there's still not a lot of data available, especially on the clinical standpoint. Yes, you have episodic data which has been captured, you'll have some sort of, some electronic form of that, but there is still not a whole volume, a large volume of data available. So can big data analytics help a rural population base? Yes, it could potentially. And the way it would help is if we can look at trends, etc., in data where it is available and apply it and kind of check and test those hypotheses in the rural environment. The actual impact will come is if we were to be able to take the technologies for capturing data down there and get that data on, then is where the true value would come.
Okay. Go ahead, Professor. Sorry.
Yeah, like, for example, think about an outbreak of an infectious disease, I think, in a rural area. And there, what didn't work, and I think you might have followed this Google flu example, but first of all, the algorithm behind it are highly questionable. Then it's also, again, to misunderstand correlation and causality. And always we want to see correlation first, and then we have in-depth investigation. So that doesn't say it would not work. What we now see, and there now was, like I gave the example in using the super computing with a Watson, and then looking for outbreaks, or also resistance of antibiotics, for example. There are, I think, can be everywhere, can be in rural, can be in a city, can be, there are no boundaries also, can be with some questions international. So I can't see of any public health questions which could not be solved or approached with the big data approach.
The other Professor Brown.
Yeah, perhaps just two comments. One is there was a question about ownership of the data. That's quite clear. It's the people themselves. There's even the right for a digital copy. But if you have this copy of your digital data, where to put it? You know, in former times we put it into a file. It doesn't work anymore. We put it on a computer, not readable anymore. So we need other visions how to deal with this. And then it really depends on what is the culture. In Hungary, for example, you showed that you could restructure the catchment areas of the hospital. That was possible because you had not a federal system. But it was a solution to the problem. In other countries, impossible because there might be a state border between this, so difficult. In Taiwan, for example, people put their personal health data on a cloud that is state-owned. Impossible in other countries. The Taiwanese believe that the government takes care of this data. In other countries, this would not be possible. And in India here, you managed, as I understood, or your plan, to give every person a bank account for the reason that the subsidies really reach this person. If India is able to roll out a system that every person will get a bank account, it should be possible to have a health account too.
Mm. That's true, and in fact, once you've amassed data base for the bank account, you have a matching database. And that's an interesting point there, Dr. Soschka, that Professor Brand made about the fact that there has to be a system tailored when it comes to the use of data and the application, as you did for Hungary, that is going to be tailored for each country. And there can be a number of restrictions in each case. Is there any core element to the way you gathered data and used it that could be applied irrespective of borders, irrespective? Is there any particular core theme that could be universal?
I think the unique patient ID that's needed for to do a reasonable data system. You need a unique patient identification.
Because many people here, for example, be off the radar just simply because
absolutely, and I think it's even in the UK it's a debate whether people need personal IDs or not or whatever. So so it's again culture, but the personal ID. Then the secondary utilization of data is an issue. Then it varies. The unique identification, and then you can do patient history. Then you can do causality and other analytics.
I want to ask Nathan how you regard, we talked about regulation in the previous session. It was something that came up earlier. How do you regard the issue of regulation when it comes to big data?
Sure. I think it's at a different... Regulation is evolving, and I think we see it evolving at different stages in different markets. When we began printing IDs on drugs, there wasn't any regulation behind that here in India. After we started printing IDs on hundreds of millions of drugs, I think the government started to take notice and say this is something that can protect our consumers, and we started to see regulatory tailwind behind these sorts of movements. And I think that has been a good way for the pharmaceutical serialization industry over the last decade and moving forward. It's sort of this partnership between government and private industry that goes back and forth. When it comes to data privacy, I think it's a really evolving issue. You talked about unique patient IDs. In India, we use typically the phone number as the unique ID. It's not personally identifiable. Whereas in the United States, it would be personally identifiable. But then the downside is that that's typically an ID for a family, not necessarily an individual. So we have to rethink how we, because we're using the phone number and not a name and not a social security number, we have to now think of that family as the unit rather than the individual as the unit. So this family has tuberculosis, this family has diabetes, and really it's an individual in that unit. But so it's very interesting how regulation changes the type of data we're able to collect and what we're able to do with that data.
So I just wanted to add a couple of things there. So I think, so regulations have in a couple of areas will impact usage of data and usage of data as you go forward. So for example, Japan had regulations that health data had to remain within the prefecture. It wasn't even portable within the country. It was within the prefecture. And then the tsunami happened, and health records of millions of people got wiped out. Okay. We've been using the word cloud very loosely right now, if I may say that. But a lot of countries do not allow their health data to go on the cloud. And they have regulations from industry to industry, for that matter. So for example, in India, I think insurance data and financial services and telco data cannot be outside the country or be on a cloud for that matter. So, the scalability question goes out of the window. And regulations vary from country to country. So we've got a question of, will a country allow data to reside only in a state or a prefecture, or is it national? And then second, to be able to truly leverage technology like big data, it will not work by setting up data centers as we know it. It would require adopting and evolving to move to the cloud. The other aspect becomes actually, nowadays, I'm a global citizen. I travel 15 days a month. Okay. My data may reside here, but I may also be living in country A, B, C over a period of time. There are questions on, if my data is generated while in country A, can it move to country B? Yeah. And I think those regulations need to evolve now. It's got to become more a global play than a country.
And it's a difficult proposition because the use of that data may vary from country to country. Even though you need to transfer it as an individual transfers borders, or crosses borders, it may not be valid overseas either. A quick comment, Professor Brand, then Dr. Soska will get you.
Even when, for example, it was mentioned by André Rüsch in the morning that the cross-border directive in Europe, there it allows that information is following a person. However, and that is really an opening directive. On the other hand, when it comes really to know legal terms in Europe, it's a difference whether you say information is following the person or the citizen, because personal ownership and citizen ownership in legal terms is different. It's a property right person, it's a paternalistic, it is where the citizen is, like I said, a shared right, a social right, a democratic really model. We will run into these problems, but I think they are solvable because the direction is clear already what that means.
I could see you were nodding when Varun was talking about the crossing the borders and where is the data held, Dr. Soska.
Yeah, and partly this was one thing I wanted to connect. For example, in Hungary, it would be forbidden to put it on an international cloud, but there is a national cloud we can put it on. The other thing is that to give a real consideration for the secondary utilization of data, we have to understand that whatever we plug into that electric plug can be hacked. And we use global products. Even if it is open source database software, if it is a global producer software, we already structuring the data in our computers and we plug it on the internet, so that can be hacked. So data protection and the ownership of data should be put on a completely different level in that sense. And that's when we can.
And there's still no guarantees.
And still no guarantees. So we have to live with it, and we have to start to use to save lives and save public money, because if we save public money, we can save more lives.
Right. Mr. Tabriz Ahmed, you.
Yeah. Hi. So my question is...
A little closer, sir, I think.
Yeah. My question is that privacy of the data is one issue, but there is another issue here, and that is how the payment mechanism will work or shared between stakeholders here. So hospital, physician, insurance company, like that. This is question number one. The second is how ready the sector is, because this is going to be a disruptive technology coming on way. So if we are not ready, some IT company will put a big data center, have position, and there will be range. Alert will be given at the mobile phone, and a payment mechanism will also work. So anybody can answer these two questions. Thank you.
Okay. Actually, Professor first. Professor Brown first.
Yeah, that's why I really believe that the most workable way, democratic way, is ownership to the citizen, but belonging to that trust system, which is a gatekeeper, which is a control system, which is can minimize. Never like you said, we have a guarantee. Never. That is mission impossible. But at least that there are, because also not all people, citizens have the same literacy. Yes, so it needs this level, and as a really neutral, most neutral, and that can only be if also the people have a voice on the one hand, and then there is like contract management and quality management, etc., other parameter. And for example, if even a public health service has an interest. Everybody has an interest, and we have to be clear about that. And then there has to be it has to be followed by incentives, whether it's getting the data free for planning or whatever. Yeah, it's different. And in the industry model, it's more paying for it, and it's also only possible again if the incentives are not monetary. And there could be different incentives. People agree on that, on different needs.
I'll do the quick comment, then I'll come to you, Nathan.
So, to your second question that you asked first. So, and I'll put it in a different way. Is there someone who's going to do an Amazon on healthcare? Definitely. Okay. The point is, will healthcare recreate itself before that? And that's, I think, coming back to what I was saying earlier, we really have to rethink of ourselves as the industry. Otherwise, someone else will do it to us. So there's no two doubts about that. And more so as we see more and more traditional, and when I use the word traditional, it may not be, and I'm not talking hundreds of years, even the last 20, 30 years, they're just changing. The face of the industry is changing. So we've got to rethink ourselves. Coming to the first part of your question, I think, so who gets what value along the way is I think the underlying question that you asked. So is the data mine or not mine? Is it a national asset? Is it not a national asset? Can it be, is it a national security risk? So one is an asset, the other is the risk side, is it a national security risk? They are very large questions. Is privacy reality, is it a myth? So I think those are questions that come along the way. So we have, there are regulations country to country that exist to protect me, but at the same time make sure national interests are protected in that manner, or taken care of. But the incentives for actually, who will benefit from the incentives is a question of the value chain. So if I was kept healthier, will pharma benefit? No, it won't. Will traditional healthcare benefit? Maybe not. Will the government benefit? Yes. Will wellness centers benefit? Maybe yes. So the value chain will shift depending on what segment you're talking about and doing. So maybe the compensation would be to the people not benefiting. So that while I may have a qualitative benefit, which is which is better health, and I may not get monetized for that, but someone else may get a monetary benefit.
And surely the country with its productivity and its benefits there, that will also benefit too. Nathan, a quick comment, then Sarah, I'll get to you, and then we have to take the.
I mean, to your point, will pharma benefit if you get better? I think the way in which we compensate pharma is broken and needs to change. And I think that we now have the technology to allow pharma to benefit based on outcomes, and doctors to benefit based on outcomes rather than based on services and products. And I think the industry has to evolve there. So
that's actually a very valid point, yeah.
So I fully agree. We have to start the cautious development of e-health, m-health ecosystems. We have to do it now. We have to start to do it. We have to generate resources. We have to think about incentive systems, and we have to think about gamification solutions. Mobile industry, pharma industry, the various industries already understand it. but we have to start to develop that new ecosystem. And it will change the medical profession, it will change nursing profession, digital technology, mobile technology, the diagnostics methods. 10 years from now will be completely different. I cannot predict what will be the prevailing technology, but everything will be mobilized. We can be sure about that.
Just a quick comment. For years we've had the ability, we've known that data can be very useful. We've had the technology to harvest and process data. I think only very, very recently, as we've developed mobile payments, do we have the ability to do what you were saying and actually compensate the consumer, the patient, for their data. And so now I think we finally have this full circle where we can begin to use that data and share the benefits with consumers in a very egalitarian way. And I think that's a fundamental change in the whole industry that we can now begin to exploit and innovate based on.
Before I get you, I think, Professor, you didn't want to. Okay, well, Professor Brown.
Yeah, and that also could also turn around who are really the winners in the end if it comes to the citizens and to the amount of people. Yeah, and then I think countries like India, they will be best off maybe, because then thinking about the really human capital of the whole population is very different than from
people can
Europe.
make a rational trade-off between whether they care more about their privacy or whether they care more about their health. I think these are some...
Let me do this, and let me just, because literally we've got a couple of minutes left, is get a line from each of you on, in the years to come, in the near future, who's going to own what data about us and why should we care or not? Nathan, you want to start with that? Based on what you see now, where do you think in a few years from now we will be in terms of how much data is available on everyone?
Well, I think Google and Facebook will own all our data. No,
They'll have everything.
No, I really don't know. I think it's out there. I think when it comes to healthcare and when it comes to pharmaceuticals, when it comes to this space, the foundation has been built. I think someone is going to take that opportunity and build a company that's going to take advantage and facilitate that. And I hope it's someone who has some ethics who's going to do that. But it's a huge opportunity. It's just sitting there.
Yeah, I think from my comments quite clear, I truly believe in Citizen and the Health Data Cooperative and globally.
That's the ideal. Do you believe it will happen?
Yes. At one point, because I think technologies and citizens are the main two drivers.
It's quite scary.
And I have most trust because thinking worldwide, and I think
it's quite scary. I think when you sign up for a Google account, all the terms and conditions which no one reads because it's like 500 pages long, actually says they can pretty much take anything they want, isn't it, Varun?
Yeah, but that would mean exactly to avoid that Google and others are the winners. But thinking that's the difference with Apple. No? Apple now really where to store, but still the ownership is different.
Trying it, Varun.
So, to your first question, who would own it? There will be a organization. It might be a public organization. It might be a coming together of the countries, various countries, or it could be a corporate enterprise for that matter.
You think there will be a central database?
It will have to, because we are blurring, as we move forward, the lines are blurring between am I Indian or am I not? So it's just blurring. So it's going to move to a point where it's a, you call it a database, a global database. Who owns it? I think it's more a question of who is the custodian of it, who protects it. Which will be the key factor, and what can you do or not do with it is what the control factor would come in, which is the organization, whatever you call it. I mean, is it a coming together of the, something like an EU of the world? Yeah, which kind of does that, or is it an enterprise which is entrusted to do it? So, for that matter.
So in Hungary, by the word of law, a physician who treats you can access all your medical records with the exception of mental illness and sexually transmitted disease. And the programmers are just programming the central data exchange platform that will access all the data. And all the transactions that were financed by health insurance fund are already there, and there are separate clinical systems in primary care, outpatient, and hospitals. So all your health data is there. And personally, when I got a Minister of State, I had to sign an official paper that I waive my privacy and authorities can see whatever they want to see. So I'm 100% transparent, so I do not even want to think about what data can exist on me. So anyway, so it's so in Hungary it is it is happening. And as a politician, I could handle it. I'm not sure that everybody could handle it, and I'm not sure that in every country it can be handled, but Hungary is progressing in a progressive way.
Well, ladies and gentlemen, obviously that proves that there is a lot more discussion on this. There's no doubt that if we have this conversation 5 years from now, we'll have a lot more to discuss with where big data has gone. But please, a big round of applause for our panelists for this session. Thank you.